Our first speaker is Dr. Burruss. She is an associate professor of surgery at Loma Linda University Medical Center, where she's co-director of the ICU and program director of the Surgical Critical Care Fellowship. She also heads the trauma prevention efforts at Loma Linda with a grant-funded hospital-based violence intervention program, and is excited to continue growing partnerships between the hospitals and the community to help reduce the injuries and death. She will be here talking about leveraging hospital and non-hospital resources for successful IPV screening.
Great, thank you so much for having me. Let me share my screen. All right, so as we think about leveraging hospital and non-hospital resources for successful IPV screening, we're going to review a couple of things, including both defining the problem as well as screening tools that are available, implementation of various settings, and then just very briefly reporting. There are many different types of elder abuse, including psychological, physical, sexual, financial abuse, and neglect. And we're going to be focusing on the physical abuse aspect of it, especially with us as trauma surgeons. That's something that we may often encounter in our patients that present to the trauma bay after an injury. We do see a lot of variations, however, in how screening and management is done, and especially as we think about training and the lack of training and the lack of confidence in being able to identify abuse and then make the appropriate referrals, thus leading to variations not only in how we as trauma surgeons, but also ED providers and nursing staff address abuse, and thus leaders really need to be able to define that harm and be able to address how we do all of these referrals in terms of identification and management. A lot of in terms of examples of what patterns we see for non-accidental trauma and suspected elder abuse comes from the European Council on Legal Medicine and their guidelines. And this includes, contusions in areas such as the scalp, injuries on wrists that might be from restraints, cluster bruising, pinches, grab marks, injuries in various stages of healing, burn injuries from, say, cigarette marks, and just injuries that don't really make sense with the pattern or the injury that was suggested upon arrival to the trauma bay. We do need to be careful, obviously, that this is not, that this is truly elder abuse and not something else, such as fractures from osteoporosis, vaginitis, urinary tract infections, underlying maybe malnutrition leading to poor wound healing. So really requires a broad differential, but in that differential, elder abuse does need to be considered. There are many screening tools that we can utilize, all that have different ease of use and different amounts of questions that are utilized. So something to consider as you're thinking about implementing a screening protocol in your institution. Some very basic questions, though, that should be included as outlined by the European Council on Legal Medicine are whether anyone's ever hurt the person, if they've been touched without consent, been made to do things without asking, scolded or threatened. Have they ever been had to sign documents that they didn't understand? Are they afraid of anyone at home? Are they alone at home a lot? Or have they ever failed to get help or have themselves be cared for when they needed help? For pre-hospital providers, especially as we think about how can we engage others both in and out of the hospital, since all of us are a little limited on time and resources, we want to engage our pre-hospital providers in that process. They're able to see the environment that these patients are living in, and oftentimes also then are able to connect with the providers of the patients in their own home. The DETECT tool is one of those screening tools that is utilized by pre-hospital providers and consists of multiple questions that has pretty good efficacy in terms of the medics being able to complete the tool and having about 16.8% of those patients, when they screen them, actually screening positive for an item. Those items that they are screening for really look at, again, the home environment. What are the living conditions? Is it safe? Is it clean? Are there open alcohol bottles? Does the caregiver appear involved or unengaged? Are there other things that just appear suspicious or out of place? and especially when it comes to personal hygiene and again, the environment itself and the cleanliness of it. The ED has taken this and really developed it a little bit further so that it can be utilized in the emergency department by any of the providers. And that can include, again, us as trauma surgeons or anyone else that really encounters these patients in the trauma bay or in the emergency department, including a very brief screen, as mentioned, with kind of questions regarding if anyone's harmed the person or failed to provide care that they might need. And if they screen positive in that brief screen, going further to a full screen and really identifying those red flags, including even repeated visits to the ED, unexplained injuries, and again, a physical examination as well that would identify injuries that are atypical for maybe the pattern that's been presented when for example, a fall, if that doesn't really account for all of the injuries that are being identified. Included in this is also a cognitive assessment, as well as the generalized elder mistreatment questions. And then from there, they're able to also engage with the care provider. And based on that, they get an assessment as to, is this someone where we suspect elder mistreatment or not? And if there is a suspicion for elder mistreatment, then they go on to report the individual and engage a team. And again, that's where then the next step has to come into place of who's going to be that team to engage with the patient and connect to law enforcement and do the actual reporting and support resources. One institution put together a vulnerable elder protection team that consisted of multiple individuals who had received additional training in geriatrics and elder abuse. And that team, anytime anyone presented to the emergency department where they suspected elder abuse based on the questions as we outlined, this team was consulted, and they did a much more thorough investigation with really a comprehensive interview, not only with the patient alone, but also all of the care providers, potentially even neighbors. They would reach out to EMS as well, again, to really get a sense of what did that home environment look like when the patient was picked up by the ambulance. And then this team also will order additional tests such as imaging or even laboratory tests such as CK levels, maybe to identify rhabdomyolysis, again, evaluating as well cognition and moving forward to get a really thorough examination of, is this truly elder abuse or something else? The social workers then from this team go on to provide counseling to victims, as well as then, if need be, involving law enforcement and adult protective services, and providing all of the coordination and care that's needed between either the ED team as well as the inpatient teams. And over a 2-year period, they found really good engagement from all of the team members, with over 200 activations in the ED. And a lot of these cases were actually not initially identified by nursing staff when the patients presented to the ED. And they found that in evaluating all these patients, about 62% of them actually had signs of physical abuse. And that required a change for 75% of those patients in their living situation or housing situations. So, really kind of outlining again that need for a coordinated effort by an interdisciplinary team to be able to not only identify these patients, but then also report and connect them to the appropriate services and resources. This has been replicated in the VA population as well, with a similar interdisciplinary team doing the screening and then the referral process, with 2% of the patients in their 251 patient sample being screened positive for elder abuse and being able to be referred to appropriate services. That, however, is very personnel intensive, right? So helpful, but it does require a very coordinated system and well-trained individuals, especially social workers, to be able to coordinate all of this care. Medicare data has the potential to help with that. And a study is underway currently that is utilizing machine learning in order to identify patterns that would suggest physical elder abuse, where they're comparing non-victimized older adults to legally adjudicated cases of physical elder abuse patients. So patients where it's been confirmed elder abuse. And with that, what they're looking at is really kind of the thought that those patients that are being physically abused are going to have fewer primary care visits, worse continuity of care, and higher utilization of both the ED and the hospital inpatient stays as well, and in much shorter periods of time. So there, again, the final data is not out yet, but there is the possibility that with being able to use that machine learning, we can utilize the electronic medical record to identify some of the high-risk patients for elder abuse. So that screening process is already done, and then its team can be put in place to then do the further investigation and coordination of care. Community service centers really also need to be involved in this process, including education of doing screening for elder abuse. But it's just a lot of studies have found that when they emphasize too much of elder abuse in their community engagement efforts, there really was poor attendance. So their recommendations have been to fold education on elder abuse into broader discussions of just care for elderly patients in general, whether that's mental health, physical health, social connections, things like that. And in addition, when we engage with our community centers and other providers in the community itself, that training component to screen for elder abuse is very important, but they also really, really need to have knowledge on how to manage that. And a lot of that was lacking in a lot of the studies, and posed some challenges then of these individuals who are in the community identifying someone who is suspected to be mistreated, but then not knowing what to do with it. So in line with that, getting law enforcement involved as well, really having that collaboration between all agencies so that as you're building your screening process and your management of how to refer patients and care for patients who are suspected of elder abuse, that law enforcement is part of that process as well. So engaging them, bringing them to the hospital, potentially having them be part of their training so that all of those lines of communication are open as you build that system. Every state here in the US, we're all mandated reporters. There are some variations from state to state, but certainly us as trauma surgeons are required to report elder abuse. And so that is either to law enforcement, adult protective services, and then there's online and also toll-free numbers that allow us to report that suspicion and be able to do the right thing for our patients. Thank you.
Excellent. Thank you so much, Dr. Burruss, for that terrific talk. Are there any questions from the public?
Well, I think we will hold questions until the end.
Okay, perfect.
And then subsequently gather them and ultimately answer them appropriately.
Sounds good.
Okay. Well, next up, we have a speaker by the name of Dr. DeAndrea Joseph. She's an assistant professor of surgery at NYU Langone Health, where she's the chief of trauma and acute care surgery. She has been awarded the Golden Apple Teaching Award and Humanitarian Award in 2010 by the governor of New York, or rather New Jersey. Her main interests are disparities in healthcare, providing for the underserved, and mentoring. She aspires to create a trauma center in her country of the Dominica, or a Central Caribbean Trauma Center someday. So Dr. Joseph, take it away, please.
Thank you, Dr. Duncan. Thank you for having me. I'm just going to go ahead and share my screen. And I wanted to apologize to the audience for, you may have seen a bit of a mix-up. Well, anyway, difference in the presentation that had to do with, the fact that I had just a little trouble getting on. So I want to share my screen, share, and then I'm going to go ahead and just, let's see here, slideshow. Right, and that was really great, Dr. Burruss, and wonderful information. I think one of the challenges is really when we talk about intimate partner violence, and I just had the opportunity to do grand rounds over in Kansas, Kansas University Medical Center, is really what to do next once this has been identified. So have no disclosure. So, and you may have touched on this a little bit, and my apologies if I have doing this again, but oftentimes people ask, what is IPV? Is that the same as domestic violence, etc.? Well, in the simplest terms, it's a pattern of assaultive and coercive behaviors. It could be physical, sexual, psychological harm by a current or former spouse or partner, and really someone with whom the person is familiar. It can occur among different types of couples, and it does not require sexual intimacy. At the center of all of this is power and control. It's really about exerting one's control over another individual. It's important to note that there are similar rates of victims amongst both sexes. But in women ages 18 to 24, it is the leading cause of serious injury and death. However, as I said previously, both men, women, and cis men or cis women or trans men or women are subject to intimate partner violence. This is an interesting statistic. If you saw the one before, where it's 1 in 3 women, 1 in 4 men, but this one talks about also sexual violence with an intimate partner, where it's 1 in 5 women and 1 in 13 men. So, when we talk specifically about elder abuse, however, the nomenclature really doesn't change, but there are certain things with which one has to be clarify, and that would be, for instance, well, first of all, this was described in the literature in the 1970s, but really had existed long before that. The challenge, as you've alluded to, Dr. Burruss, is the collection of epidemiological data and good studies that really truly describe the prevalence and the extent of intimate partner violence in that population. But in some studies, it ranges anywhere from 7.6 to 10%. What it is not different from the abuse in the remainder of the population. It is about physical abuse, sexual abuse, emotional, psychological abuse. The two other things that are of import here, specifically neglect and financial abuse. So when we speak of neglect, that can present itself in many different ways, and I know that we've all seen this, whether this person is someone who is living with family, or even sometimes, unfortunately, a person who lives in a skilled facility. And that is not paying attention to the person's basic needs. And you'll see here on this diagram that the types of abuse ranges in the pattern you see here. So there are risk factors like anything else. In terms of the perpetrator, what is a particular risk factor when an individual, and there are a whole range of these things, but I thought it was important to point out persons with mental health issues who are subject to stress, isolation, are more likely to be a perpetrator. You can imagine how COVID actually affected those kinds of interactions. Having the victim be dependent on that perpetrator, and also in terms of societal structures. And what I mean by that is specifically, again, going back and really not trying to misjudge or misappropriate, maybe that's the wrong word, but misrepresent skilled nursing facilities. But there are reports in some studies of where staffing models are not consistent with the volume of the patients or the kinds of patients, that can translate into frustration by that staff and then subsequently taking it out on the person. With respect to the victim, different kinds of factors contribute to the possibility of intimate partner violence, and that includes someone with dementia, with functional impairment. We're all familiar with the fragility scale and how that can impact a patient's status, but both before and after an injury. That also translates into someone's dependence, and that then can subsequently translate into a risk factor for intimate partner violence. We're often faced with how do we manage this, right? In particular, in our world as the acute care surgeon, what is our responsibility? How do we even understand this? Well, there's certain types of things that can lead us and clue us into what the patient may be subject to. That's the types of injuries, when you find that there are different stages of bruising in odd places. Interestingly, sacral decubiti can be indicators of people who are in neglect. Now, I remember when I was a resident and medical student, if somebody had a sacral decubit, it was 100% the person hadn't been moved. We've since realized that there are other things that impact that include things like the nutritional status, etc. But it's important to note that all this comes back to the issue of the neglect of the individual. And so a person presented with a sacral decubitus, while that may not be the only reason, certainly should clue us into the possibility of neglect. Persons unable to afford their medications also is a sign of maybe someone being in control of their financial status or their finances. And the thing is, and this is taken from an article just published about a year ago, that we can do ranges from engaging adult protective services, community goers, the police, sometimes maybe the first responder, legal agencies, physicians ourselves playing a critical role in understanding. We are also mandatory reporters of elder abuse in all states that have mandatory reporting laws. The issue is whether these states whether you live in a state that has that or not. This also tries to, place in the cartoon how all of these issues sort of kind of play into the issue of a person becoming a victim or a perpetrator when you have difficulties, life vulnerability. So we're talking about that at the individual level. When we speak of the interpersonal, the relationship with the perpetrator, the neighbors, the friends, family, is there a support system? And we go to the community level as the next level. And it also gives us a map, if you would, of how we can intervene in stopping, breaking that cycle. We need to learn how to identify and recognize the red flags, investigate unusual findings, how we can provide support in the slide that I referred to earlier, and that I showed earlier that shows that sometimes referring to the appropriate authorities and knowing when to make the right referral, and I apologize for the typo, and when to report. So it's hard to kind of fit everything into 8 or 9 minutes. I know there's so much to be said, but what the take home message here has to be that elder abuse is very real and it's underreported. There's several factors that play a role in why that is the case. The individual who may not have the capacity to speak on their behalf, or there are in certain cultures, for example, the elder speaking against the person who is supporting them is seen as, you just don't do that. Certain patients are at increased risk, as I described earlier, and these are the ones who are most vulnerable. And not every elder is vulnerable, but certain people who are frail and people who have comorbid injuries. It is always, it's not easy to ascertain the types of injuries, but you should raise the question. And one of the things that I shared at different talks is that we have incorporated into our tertiary survey intimate partner violence screening question. So, although it's done as a standard at the entry, most patients are not really ready to hear it. So we've incorporated that into our screening with our patients across the board. And one thing that I want to just give a plug for again is the need to really fully understand what the prevalence is in the group of patients that we see. And we have had a multi-center trial looking at that. So in short, elder abuse can be stopped. We are in a unique position where we can do that and we can contribute to that. And I know that Dr. Burruss gave several very helpful bits of information. And so that I don't go over my time, which I already did, I'm going to stop sharing and happy to take questions when you have them. Thank you so much.
Okay, Dr. Palacio will introduce the next speaker. We'll take questions at the end.
Very good.
Thank you very much for that, Dr. Joseph.
Thank you so much, Dr. Joseph. Our next speaker is Dr. Castater. She is a quote-unquote non-traditional student who decided to pursue medicine after being a victim of violence. She's currently an assistant professor of surgery at Morehouse School of Medicine and a trauma surgeon at Grady Memorial Hospital. Her research interests include trauma-informed care, violence prevention, healthcare disparities, and post-traumatic stress disorder, among other topics. She has spoken multiple times on post-traumatic stress disorder and on her path from trauma survivor to trauma surgeon. She's here to talk about leveraging hospital and non-hospital resources for a successful fall prevention program. Welcome.
Thank you so much for that. I'm very happy to be here among all these distinguished speakers. I'm going to go ahead and share my screen. Hopefully I can do that successfully. Okay. Okay. Can everyone see that?
Yes, we can see your screen.
Yes.
Okay. Sorry. My slides aren't advancing. Sorry, 1 second. I apologize. Okay. Is it in presentation? Very sorry.
It doesn't look like it's in presentation mode.
Yeah, it's not presenting
Often
for
in
me.
the lower
Yeah.
right.
Yep. Slideshow. There we go. Okay. I just had to click it a few times. Okay. Apologies. So I'm going to be talking about leveraging hospital and non-hospital resources for successful fall prevention programs. I don't have any disclosures. Essentially, there are, sorry about that. There's a number of falls that happen in our community. With the aging of our population, about 33% of adults over the age of 65 and 50% over 80 will have a fall within 1 year. And about 20% of these falls leads to injuries and many to subsequent death. So it's important to remember that when these falls happen, there's multiple opportunities along the chain to institute fall prevention strategies. Some of these areas, first it starts outside of the hospital, so that's pre-hospital and EMS. Then the patient is brought to the emergency room. You have strategies you can implement there. If a patient is admitted, there's strategies that you can implement within the inpatient setting. And then any patients that are discharged, or if they're not admitted, there's community strategies that can be introduced. So from an EMS perspective, there's a number of different strategies that different hospitals can institute. Our EMS providers are really our first line at seeing these patients when they're outside of the hospital. They're the ones that are actually seeing them in their house setting. One thing that they can do is basically just provide resources so that they can then, basically go into the community and figure out how to minimize the risks that are within their homes. One advantage of this strategy is that if EMS goes and is responding to one elder that's in the home, likely many times there's more elders in the home. So this is a strategy that can hit not just one patient, but potentially other future patients. Once a patient comes into the emergency room, there are a number of different strategies that can happen. Many hospitals have nurses that screen all patients that are over 65 in various ways. One thing is that you can use the timed get up and go. And then if you have an abnormal timed get up and go result, you basically get referred to physical therapy, social work, home health, or geriatric nurse liaisons. An abnormal timed get up and go, just so that we all know, is greater than 12 seconds. Sometimes I feel like I actually fall into that category, but I digress. The other thing that a lot of emergency rooms do is use other screening tools. One that is very good is the Morse Fall Scale. And what this can do is identify patients who are being admitted that are of risk of in-hospital falls. The Morse Fall Scale looks like this. Essentially, it's just a 6-item questionnaire where you do a scale and a scoring system, and it's very, very sensitive at identifying patients that are at risks of falls. And then these are the patients that, when you're in the hospital, you can institute strategies to A, prevent these falls from happening, and B, have early mobilization strategies to really help these patients to not become deconditioned. Once patients are in the hospital, and I think we all have probably experienced this, there's really not that many great things that can help patients to not fall. Some of the strategies that are used are alarms. A lot of hospitals use this, but they are really not good at preventing a fall. It's basically just going to tell you when a patient has gotten out of bed and possibly has already fallen. Sitters are expensive. There's very low level of evidence suggesting that they can be successful at decreasing falls. Intentional rounding can have some limited success, but it's very hard to implement successfully because you need to have the resources and staff to do this. But it can be something that is successful if you have enough resources to actually implement it. Patient education can be effective, but that has to be for patients that don't have any sort of cognitive impairment, obviously. And so for a lot of the patients coming in the hospital, anyone with dementia or any sort of head injury, they don't fall into this category. One thing that can help is environmental modifications. These can be things like bed rails, and those can actually be pretty successful. But at the same time, if patients are reasonably mobile, it is not necessarily the best thing. Many hospitals use restraints, and there's so many risks that are associated with this. So as much as possible, we really want to try to reduce them. They increase chances of delirium in patients, which actually increases fall risk. Also, we put on all these non-slip socks onto patients. The problem with those is a lot of times they actually bunch up in various ways and can actually make patients trip and fall more easily. So I know that it's very difficult. I've put a whole slide of things that we do, and none of those things really work very well. I know that can seem a little disheartening, but the main thing that we want to remember is that we really just want to institute early mobilization strategies, and that's with physical therapy and nurse-driven strategies. If we can identify patients that are at risk of falling and use these fall prevention strategies, we can really reduce their risk while they're in the hospital. And then what we want to do is see who is at risk of falling again once they leave the hospital so that we can prevent them coming back in with other falls. There, like I said, nurse-driven protocols are the main way that you can increase safe early mobilization of patients, and then you improve the overall culture in the hospital of getting patients out of bed and getting them moving, and actually getting them better and able to get out of the hospital sooner. There are a number of resources that hospitals can use in order to implement in-hospital and also out-of-hospital strategies. The Agency for Healthcare Research and Quality has a number of fall prevention training programs that you can easily access on the internet. Also, the CDC has a Stopping Elderly Accidents, Deaths, and Injuries, which is STEADY, which is a really great acronym. And that STEADY initiative involves both inpatient strategies and also outpatient strategies. So once a patient is outside of the hospital, what we really want to do is try to figure out what are the main things that are causing them to be at risk. The STEADY program has a very easy three-question screening. They have this kind of more complex table that you see on the right side of your screen, but what they really say that you can do is just ask patients, do you feel unsteady when you're walking or standing? Do you worry that you're going to fall? And have you had any falls in the If patients screen positive for one or more of these, they're at increased risk of a fall. The number one thing associated with fall risk reduction in the community is going to be graduated exercise programs. And this is demonstrated throughout the literature. There's numerous papers that talk about ways that you can prevent falls by getting the people, these patients in the community moving and walking. Other key interventions include things like assistive technology, having people go into patient homes and assess the environment, figure out what fall risks are there, things like rugs and things like that. Also going over patients' medications, looking at their shoes, doing vision screens. When you think about fall risks, you can really divide it into intrinsic and extrinsic factors. Intrinsic is obviously going to be anything that's associated with somebody. So that's, their vision, their cardiovascular health, if they have any cognitive impairment, if they're incontinent and so they have to get up out of bed in the middle of the night, if they have arthritis or pain, if they can't sleep, or if they have depression. Extrinsic things are things you want to really try to adjust that are around them. So that's going to be any medications that they're on that are going to cause them to be more altered and increase fall risk. Things like footwear that is sensible, backless shoes and things like that are not good for older patients. And then also assessing the environment, making sure that patients have grab bars, that they don't have floor rugs, that there's good lighting, and that there's not things that you can trip and fall over. And once again, there's a number of community resources. The CDC, which I already talked about, the STEADY initiative has an older adult fall prevention strategy in the community, and this is a really great resource. Also, the National Council on Aging has a number of prevention, has a whole prevention resource center that can be used on an outpatient basis by primary care providers or in the hospital setting when patients are discharged from the hospital. Okay, oops, sorry about that. And I'm happy to take any questions.
Yeah, thank you
we're
for
doing
that. We will now pivot to the closer, and the closer is Dr. Deb Kuhls, who is Professor of Surgery and Acute Care Surgery Division Chief at the School of Medicine at UNLV and Chief of Trauma at the University Medical Center's Adult and Pediatric Trauma Center in Las Vegas. She is the second Vice President-elect of the ACS and is the immediate past chair of the Trauma Prevention Coalition and Society of Critical Care Medicine, the surgery section. Now, she served as the chair of the COT, Injury Prevention and Control Committee from 2012 through 2020, which developed a consensus-based medical public health approach to firearm injury prevention. Her awards include the SCCM Shubin Will Master Clinician / Teacher Award and the National Safety Council of Surgeons Award for service to safety. Now she has granted, she has grant support activities in traffic safety, disaster preparedness, and firearm injury prevention. And she'll be talking about firearm guidance in older adults with dementia. So Dr. Kuhls, please take it away.
Thank you. Let me share my slides. Okay, can everyone see my slides?
Yes.
Okay, great. So that is the topic I'm going to talk about. I don't have any relevant disclosures. And just to kind of remind everyone, we have a growing elderly or older adult population. And by 2030, it's estimated that over a quarter of Americans will be 65 years or older. And of that older population, about a third of them owns a gun, and another 12% lives with someone who's a gun owner. And just to kind of review, suicide and that it is also very common in older adults, particularly in the male population. Blue represents male and orange female. I'm going to focus really on the males. And when we look at firearms and how they're involved in suicide, they're involved a little over 30% of the attempts, but they're very fatal and therefore result in suicide in about 70% of those cases. And I'd like to acknowledge that I think my early introduction to older adults and firearm injuries really I have to credit Dr. Zara Cooper for really starting to enlighten me and get interested in this population in particular. If we look at suicide and firearms in the home, we can see that it really increases the risk of suicide by more than 2 times. And then if it is a handgun, it increases by more than 3 times the baseline rate. If the firearm is unlocked, it's almost 10 times the rate or the likelihood of suicide. And furthermore, if it is loaded. So some of these topics are known safety measures, and they're very, very important in this patient population. Also, just to look at dementia and the population that is growing as well as the older adult population, is that we can see that it is dramatically increasing. I know there are many attempts to figure out what is really causing dementia, but 60% of people with dementia live in a home with a firearm. And as we look at the progression of that disease, which I'll talk about a little bit later, that is a very, very concerning trend. And when we look at dementia, we know that it increases the risk of suicide. We don't really have great data on this still, but we know that it increases the risk if there's a firearm in the home, not only of a risk to self, but risk to others. We know that with dementia, there are many impacts upon both mental health, mood, impulsivity, and so forth that can really result in harm to self or others. And we think that, again, about 60% of these households have a firearm. Many are unlocked and many are loaded. And I apologize, the lights in my office are motion sensitive, so I think they've just gone off. And again, we're kind of lacking really accurate numbers with regards to actual firearm injuries related to dementia. So the Alzheimer's Association has come up with many recommendations, and I'll go into some of the potential action steps we can take on each one of those in a few minutes, but it's recommended to actually remove the gun or firearm from the home, and they recommend that in addition to initial safe storage, but it's thought that safe storage may not really be enough, particularly if a person with dementia becomes very afraid. And the major reason for owning a gun is really self-protection in this population, that they may aggressively try to unsecure it, if you will. And so the recommendation is really to remove the guns from the home. And if possible, to put a plan in place for retiring the firearm. Again, I'll have a little tool to refer to that in just a few minutes. And whatever the plans are, including inheritance and disposal, sort of stick to them as time goes on. Early in the course of this disease, it is thought a really good time to have a conversation, perhaps pairing it with other advanced planning initiatives, like who should inherit the family valuables and so forth, and at the same time really talk about firearms. This is a survey, the results of the survey of older adults. And we can see that many of them feel very comfortable in a healthcare provider bringing up the topic and actually to discuss safety initiatives. So more than half are comfortable with a physician asking them about guns in the home and safety. This is another study, and this is an interesting, I would just say there's been a lot of really recent work done in this area. And this is a survey of it's called the National Firearms Survey. So everyone who's surveyed actually either owns a gun or lives in a home with a gun. And they parsed out those that were considered caregivers to Alzheimer's or related dementia patients. And you can see that a very significant, well over 50% of people feel that a healthcare professional should discuss firearm safety during routine visits, as well as other safety maneuvers. But very few of them indicate that they've actually had such a conversation with the healthcare provider. And many times, and it's recommended that the caregiver attend the office visit along with the patient. And this is another survey just of 50 to 80-year-olds with or without dementia. And they talk about the acceptability, again, of screening for firearm ownership, as well as safety training. And we can see, again, well over 50% are very comfortable with healthcare providers accomplishing this. And this is what's called a safety in dementia trial that actually is developing an online sort of safety tool, because the number of older Americans is really growing. The number of people with dementia is really growing. And so this is an online survey tool that's being developed for caregivers. And it is assessing assessment not only for firearm safety, but driving and home safety, such as cooking. And in this very preliminary study, it was felt that they felt more comfortable talking about safety and firearms, as well as they were more confident. And this was again caregivers. So one simple screening tool is very straightforward. You know, are there firearms in the home? Do any of these belong to you, the patient? Are they stored? And then, of course, does the patient have access to firearms? And it's really important to focus on safety and well-being for those that are vulnerable, not only for the person with dementia, but for other vulnerable populations as well. And it's recommended that a combination of both education and information be provided. And it's important to be, of course, respectful and culturally sensitive, depending upon the area of the country. There may be a long history of hunting and so forth. And again, sort of advanced directives for firearms is really important. This is a tool that was published in the Annals of Internal Medicine in 2018 that could be used along with other advanced directives, and it's really direction to the family when it's decided that the firearms should not be, you know, in the home any longer for safety reasons, that they desire a specific person to indicate that to and to pass along responsibility for firearms. Some actual tools, many of us healthcare professionals are not really comfortable really talking to our patients about firearms. So I wanted to give a few resources. So the Bullet Points project is an online tool. I've given the website on the bottom, and there's CME available to really train us not only about how to talk to our patients about firearms, but to become more knowledgeable about firearms. And this is just one example that really just describes what the objectives are, and it's really to describe the clinician's role, help to identify patients who are at risk. This would include the population we're talking about today, and how to really engage in conversations, has some sample conversations, and then how to really apply this to our practices. This is another resource that was developed by the American College of Surgeons Committee on Trauma. Several people on the panel today were instrumental in its development. And this is a very recent, very comprehensive tool, again, that was developed by the Committee on Trauma. And it goes through many of the very basics about firearm injury prevention, about safety handling and so forth. And then it goes on to actually give resources about, additional safety maneuvers of all populations. And then it does include some information about safe storage and transportations. And then, if it's a child, what action to take, and if it's an older adult, some potential actions. And it's really important to, of course, talk to our patients, including our older patients, about their risk of firearm injury. And community outreach programs, and lots of resources that I wanted to pass on. So in summary, we know that this is a growing public health issue, particularly in this population, and that screening can really be incorporated as part of a general safety screen. It's acceptable by patients and caregivers for us to screen and to talk about firearms being removed from a home, for instance. There's training and information available. There's online tools that are in development, along with good scientifically based testing of those. And I really wanted to, again, thank the AAST and the Prevention Committee for this opportunity. Thank you.
Thank you so much, Dr. Kuhls. That was great. I think we're done with our panelists. Are there any questions from the audience? Okay, I don't see anything in the chat either. I do have a question for that would be for Dr. Burruss. For those screening tools that you talked about, how can we make sure that rural facilities and level 3s, level 4s, they get involved into this? Because some of those patients, or the early patients, they get to those hospitals, they don't come to the big level 2s, level 3 trauma centers. How do you think we can get them involved? Or are there any easy way they can screen? I know you mentioned one that was only 3 steps, but something very quick that they can be of use.
Yeah, I mean, every hospital is going to have their own different set of resources, whether it comes to the number of ED providers, social workers, in-house trauma surgeons, not in-house, things like that. So they're going to have to assess that, but it's going to take a champion at the hospital that's really going to lead the effort, right? So they need to be able to identify perform a gap analysis, see what resources are in place, and then be able to decide what best screening tools are in place. And are they going to coordinate this effort with screening in the hospital, and then coordinating with law enforcement and community agencies, or are they going to do a lot more of the coordination of care from the hospital itself if they have the social workers and resources to do that?
Very good. Thank you.
Yeah, I have a question for for Dr. Joseph. The statistics of 1 in 5 women or 1 in 13 men being susceptible to sexual abuse from their intimate partners is pretty striking. And I'm wondering, as clinicians, when we have patients come in, either elderly or younger, but we're expected to report based on the laws. And I'm wondering how not to overstep boundaries, because there are times in which we will have to report, but the caregiver that brings the patient in may have some opposition to that, or how do we go about navigating that? Because it gets a little complex.
Excuse me. Thank you, Dr. Duncan. That's a question that I think it has so many levels in it, because part of the question, I think, is really speaking to our own discomfort with addressing the complexity of IPV and when it crosses into certain boundaries. And the numbers are striking. And I became really passionate about that whole aspect of medicine when I realized how prevalent and common it was. And what I would say to you is part of the way you get around the discomfort in approaching the question is being educated, being comfortable, having set tools that can identify, that can be best presented to the person, that they feel safe and comfortable in relating information to you. I think it involves training of the person who is asking the question to create a setting where that individual feels that they can trust the system. And so that is not something that you can simply just go, well, this is what I need to read off. So it involves also a little bit of education in the background, which is one of the things I teach on our trauma CME conference, where we have the usual topics, and then one of that is intimate partner violence, because I think a big part of this, people have to feel comfortable that it's okay to ask these questions. It's okay if you came in and somebody said, I have this big gaping wound on my leg. We want to know, well, how long has it been there, and so forth and so on. And so we need to feel comfortable about this big gaping wound that allows a person to be a victim or frankly a perpetrator. I don't know if I really answered your question, but I hope I did.
Very good. And I do have one more question for Dr. Castater. For those newly graduates, for those new trauma surgeons that are listening to you, what can you tell them? What advice can you give them so that we don't see these recurrent falls in the elderly? We discharge the patients and then they come back a few months later with the same problem. What can we do from our standpoint as a trauma surgeon to avoid this problem?
Yeah, I think one of the biggest things is just always having a heightened awareness and understanding actually the importance and severity of really, screening and knowing that these patients are at increased risk of falls. I think that, as trainees, I think we all remember this, you have this large volume of patients that you're taking care of. It can become a little bit easy to treat each patient kind of like a number. And really having more of a world view and considering that, every patient that you're taking care of, thinking, how can we actually prevent this person from continuing, to have a problem or be at risk? It just takes a certain amount of just broad thinking, I think.
In regards to falls, it's near and dear to my heart, and most of you know that my dad died secondary to complications from a fall. So it's really important that I push the envelope and we push the envelope on this issue. And actually in Ventura County, we have an EMS-driven fall prevention program, and the process begins in the field. Now the AAST has come on board, both the geriatric and the prevention committees are working in concert to put on Stop the Falls event at our upcoming meeting in September, which is a community event, and it's going to be multidisciplinary. We'll go out to a nursing home to provide services and educate the staff and those that live there about the importance of falls and how they can prevent themselves from falling. So that's coming down the pike, and I truly appreciate you giving a talk about falls. And I'm going to segue to Dr. Kuhls. It's so difficult to have conversations with patients in regards to firearms, and I'm wondering how do we determine when the correct time is to have that conversation before they get demented? You know, we never know when the dementia is going to set in, although there may be signs coming on bit by bit. But I'm wondering how to determine that, and also how a surgeon can become an advocate in terms of having bills pushed through legislature to be able to make a difference in our patients' lives.
So good questions. I think I really agree with a lot of the actions and recommendations of both geriatric societies and the Alzheimer's Association as well, to have the conversation early. And I think as we approach really treating older adults, when we ask them, do they have a kind of advanced care guidance for their loved ones, if you will, that we should really kind of broaden that to, and you know, and it would be important for you to also address, you know, your possessions, and you know, including firearms. Who would you like them passed on to? Also the form that I had on one of my slides that was published in the Annals of Internal Medicine is a natural forum to say, you know, you may want to think about this, and who you would want to pass on your firearms to, or in the event that you're no longer able to make your own decisions, who would that person be to determine what should happen to these possessions? I also think that just practicing it and incorporating it in things that we're comfortable with is really important, and I think it makes it easier to do. The bullet points, I can't speak highly enough about those. I've been through many of their online modules, and they're really aimed at getting us comfortable about talking about the topic. I think we all remember going to medical school and saying like, oh, we're supposed to take a sexual history on someone. And we're all like, what? And it's really through practice and guidance that we've, you know, it's hopefully part of all of our routines. And this would be one of the things that would be included in routine conversations.
Well, I know the hour is late, but I really want each of the presenters to give us a one-sentence take-home message so that we can take it and run with it. So we can start off with Dr. Castater.
I just really felt like one of the most pervasive themes across all of the speakers was really thinking about these topics and realizing that they're important, and also becoming comfortable with bringing these topics up to our older population. And that, you know, every single person that spoke, whether it was falls or IPV or guns, it all kind of had that same pervasive message that we have to be aware. And then we also need to talk to patients and feel comfortable doing that.
Thank you. Dr. Joseph?
Real privilege, and I thank you for bringing me to the panel here. I think this is a not talked about enough subject, and in particular in the elderly population. I do believe it's a lot more prevalent than we think it is, and it's just really great to hear from leaders in the field, and you know, especially this team, Dr. Kuhls here, and her passion and how she continues to address the issue of violence in the community. So thank you. That's would be my takeaway. Thanks.
Dr. Burruss?
I think, as we heard, that a lot of these issues really take an interdisciplinary team approach to address, whether it's falls, elder abuse, gun violence, all of those, but it still takes someone to recognize the problem, right? So, and that is going to really a lot of times be us as trauma surgeons engaging with these patients that are here for some unknown reason, right? That we may identify that elder abuse, the dementia that led to the incidental gunshot wound or the fall. And so we're that first person that can really screen the patient and then really utilize inpatient and outpatient resources to get the care that our patients need.
Thank you. Dr. Kuhls?
Such great comments. It's a hard act to follow. All of these great suggestions. I look at each patient with an injury prevention lens. And I think, as was mentioned earlier, no matter how an older adult comes to our attention, whether it's as a result of a fall or some other injury, to really take a comprehensive look with the patient and their family and with a multidisciplinary approach to how can we keep them injury-free for the rest of their time on Earth. And I think if we have that lens, we have a unique perspective because we see the result of injury, and really not many other specialties do. So I think we really have a unique perspective and responsibility.
Yes, all great comments from everyone. And I'd like to thank the AAST for the privilege of the platform again, and to thank all those attending today's grand rounds.